the senior most faculty in Tamil Nadu, Dr. Mridubhashini Madam, joining us to enlighten us about recurrent pregnancy loss. It's a great pleasure to welcome you, Madam.
Thank you.
Sitting at your home, yes, sitting at your home and listening to Stalwart is the best time, I think, best thing which we have now with the technology. So can you please display Madam's CV? Oh, you're first putting this. Okay, fine. Yeah. Everybody knows about her, but just to know in detail, Dr. Mridubhashini, Madam, has completed an MBBS from Stanley, and she's a gold medalist in medicine and pharmacology. She obtained her PG training in University of Manitoba, Canada, and she's a fellow of Royal College of Surgeons of Canada. She is trained in laparoscopy, colposcopy, gynec endoscopy in Germany, and infertility management under Professor Ratnam of Singapore. She is also a certified specialist in MR-guided focused ultrasound treatment of adenomyosis and fibroids, one of the only two gynecologists certified in Southeast Asia. Prior to her association with motherhood, Dr. Mridubhashini was the head of the Department of Obstetrics and Gynecology at Sri Ramakrishna Hospital. She is a clinical director at Women's Center and clinical director at Assisted Reproductive Technology Center, a unit of Women's Center. Welcome you, Madam, once again. Over
Thank
to you.
you.
Yes. You can share the slides.
Slides, yeah. Full screen. You see the slides?
Yes, yes, Madam.
Okay. It's a pleasure for me to be with you this afternoon. And I have missed being with Oxy for a long period of time now. And it's really a pleasure. And thank you for the invitation. Can you hear me?
Yes, ma'am. Very clear. Yeah.
Okay. I think I'll get going with the slides. Yeah. Okay, move now. Okay. I think you can see the slides now. Can I have that off the screen?
Yes, Madam. It is there. Yeah.
Okay. Off the screen. Okay. The topic you've given me is a very challenging topic. It's recurrent pregnancy loss. And I think we have to change the way we think about recurrent pregnancy loss. And the last few years have seen such a lot of development in this field. Now, worldwide, it's become similar to reproductive medicine departments, the recurrent pregnancy losses. We have huge symposiums that go for 3 days and 5 days worldwide. And a lot of people are members of a worldwide recurrent pregnancy loss society as well. So I think this is something that we need to think about and discuss about. Not all the answers are available as yet, but a lot of fresh thinking has gone into it. And we look at it in the way that is being looked at by the majority of professional societies now. First of all, recurrent pregnancy loss should not be looked at as a disease, as a problem on its own. And it's only a symptom, and it's a symptom fairly similar to pyrexia of unknown origin. When you say PUO, that's your diagnosis in a patient, it's actually not a diagnosis, it's just a symptom. And we've got to go to the bottom of it and find out what the reason for it. The same way when you say RPL, it is not a disease to be treated. Same way in every individual, it's only a symptom. And I think it is not to be treated as an entity which has a single modality of treatment. It's only a symptom. And the first step in the management should be to investigate and find the underlying cause for this. Appropriate management should be decided upon only when the cause is found out or ruled out. Treating all RPL as an immune rejection of an allograft is not the right approach, which is what is being done in the majority of places now. We treat all of RPL as a single disease with a single type of approach and a single type of medications. which I think is the reason that nobody has found out one cure for recurrent pregnancy. Most of us tend to treat them either with progesterone or with management of as though it is a thrombophilia, which is not really the case. So we look at today what the causes are and how you should be approaching this. It is moving. Okay. So why should we investigate people who go through recurrent pregnancy losses? Because there is an increased psychological risk, increased obstetric risk in the future, FGR, placental abruptions and stillbirths, increased medical risk of morbidities later. It may be thrombotic morbidities and cardiovascular morbidities. And when should we investigate? It should be done after 2 losses. It's not after 3 losses. Risk of further miscarriage after 2 losses is 30%, and risk of after 3 losses is 33%. So it should not be treated any differently. And most people today worldwide agree that the investigations for recurrent pregnancy loss should be started after 2 losses and not after 3 losses. And biochemical pregnancies should be counted as a loss as well. And RPL need not be sequential losses. Even without a sequential 2 losses, it can be separated by a normal pregnancy in between. It still has to be considered if there are 2 losses at any gestational age. So current recommendation is after 2 losses, you start investigating them, and it's not 3 losses. And earlier evaluation is needed if couple had difficulty in conceiving. In other words, if this couple had been treated for infertility, and if there's a loss of pregnancy after fertility management, and if the woman is older than 35 years, and in a situation where fetal cardiac activity is identified prior to a loss. But these are the situations where we should start the investigations early and not later. So how should we think about it? We really should think about an RPL like a seed growing. Just as the seed is growing, there is the seed, there is the soil, and there is an environment around it. And any of them can be at fault if the growth doesn't happen. The same way in RPL, it may be the embryo at fault, it may be the endometrium at fault, or the environment around them can be at fault, or the interaction between any of these things can be at fault. So if you look at it like a seed, soil, environment interaction, I think it becomes much more apparent that in any kind of problem in a recurrent pregnancy loss can be either in the embryo or in the endometrium or in the uterus or in the environment. So all of them cannot be treated alike and in the same management protocol. So we consider the sperm, oocyte, and the embryo as the seed, the endometrium and the uterus as the soil, and all other endocrine, immunological, and other interactions as the environmental factors. So what about the seed? When you're talking about the seed, the first thing that you talk about is the male gamete. And male gamete was never thought about something that we needed to consider if there's an early pregnancy loss. But now it's become extremely clear that sperm can be a cause. And sperm DNA damage is associated with poor embryo quality and development. And it's been proved in the last decade and a half extremely clearly that if the damage is there in the sperm DNA, it can lead to miscarriages again and again. And this is a little difficult. Sperm DNA damage is not apparent looking at it. These are not dead sperms. These are live sperms, which otherwise may look normal. So you have to be doing the specific, using the specific technology for you to find out whether there is a sperm DNA damage or not. So DNA fragmentation in many studies over the last decade, it's been shown that the high sperm DNA levels have been associated with lower live birth rates and especially increased early miscarriages. Early miscarriages or miscarriages in the early part of pregnancy have been associated with RPL. So repeated miscarriages especially, I think it becomes very important for us to know about the sperm DNA integrity. Now, can it be measured with that by us here? I think the answer is, of course, yes. And I think it's being done all over India, and most of the IVF units have a way of checking for sperm DNA. But the ideal method of checking is something called SCSA, or sperm chromatin structure assay. This assay is a good assay because it checks thousands of sperms. The rest of them, a lot of other tests check only about 4 or 5 sperms under the microscope by a trained embryologist. Whereas here, I think SCSA testing is done by equipment and by computer systems and AI to find out what number of sperms are affected in a particular sample or so. And one of the leading laboratories, andrology laboratories, is in Coimbatore, and it is getting samples from all over India. And that's why, and for the last 10 years, and that is why the number of samples from this lab, which have been reported in international journals, is extremely high. And these are Indian samples as well. More than 27,000 samples have been tested in the last first decade of its activities. And out of the samples that have been checked for DNA integrity, more than 25% of the DNA has been found to be abnormal. Integrity is not there. Nearly 4 out of 10 patients have abnormal sperm DNA integrity. And if you look at it at the next step, is it associated with other sperm problems? In other words, doing a conventional sperm analysis, will you be able to say that this patient probably has a high DFI and therefore will have a problem with the sperm and normal pregnancy happening at the end of it? It is not. And that's why it's a little bit more difficult, and you have to check specifically for sperm DFI by the appropriate testing methodology, which is an SCSA, which is available for people all over India today. And you look at these numbers, it's oligospermic patients had a DFI in the rate of 50% or so. Okay, half of it also had a high DNA fragmentation. Whereas zoospermic patients, in other words, all other parameters of the sperm being normal, they still can have an abnormal sperm DNA integrity. So in other words, unless you're checking for DFI by the appropriate testing, you may miss the whole thing. So, but then 1/3 of these patients had sperm DNA not adequately normal. And does it have a relationship to anything at all in the environment? Yes, I think some associations have been very definitely found. Age is one of them, and it may come as a new information for you. Patients under 35 years may have a sperm DFI, which is abnormal as well, but that is more in the range of 20-25%. Whereas you can see that according to the age group, it goes higher up, and the dramatic change seems to happen around the age of 37, which means that more than half the samples around age 37 and beyond in the male are abnormal. And if you equate it to the females, you find that all of the chromosomal abnormalities in the female that affect the babies happen after the age of 37. 37 is the same age that we consider as a crucial age in the female. And we think that in the male, this kind of a change does not happen. But definitely looking at the sperm in much detail, it does seem to happen. So we made it a standard today in our RPL patients for any male, even otherwise, even in fertility management as well. Any male over 37, we don't do the procedures unless we check the DFI first. And if the DFI is higher, we manage that as a first modality of treatment before we even start doing a test tube baby. And this again may be a news for you. And the DFI value, which profession is it higher? In India, when I ask this question, a lot of people would answer and say electromagnetic things, cell phones in the pocket, and a lot of other things connected to computers and electrical things, and a lot of other situational things. But it's much higher in farmers in India, in our samples, which are a large number of samples being checked. Adverse effects of pesticides and fertilizers on male reproductive health seems to be much higher in India rather than anywhere else that this has been checked. And I think almost half, 47% of people who are hands-on farmers have very high poor DNA samples. And in miscarriages as well, people who reported repeated miscarriages and the DNA fragmentation rates are high. So there's a very good reason for us to keep this in mind and check the sperm for DFI. Ordinary sperm analysis is not going to give you this information, but laboratories, advanced andrology laboratories are available for most of us today, and it can be checked and these values are available. So there is a clear evidence that DNA damage can be caused by unhealthy lifestyle, aging, varicocele, chemicals, medications, etc. Lifestyle changes, weight management, medication management, varicocele repair, these kind of things can give them a relief, and they can reduce the DNA fragmentation drastically. And current sperm separation techniques in the lab also can isolate abnormal sperm from normal. So whenever we are going for ART procedures and we have to deal with the sperm with a high DNA count, this is something that we would do and use the sperm with a better DNA integrity. The same way, oocyte factor also, I think we should be thinking about recurrent early pregnancy losses. All of the maternal factors can be involved in this: caffeine, smoking, alcohol, not at all uncommon in today's society in young women, and obesity. A good proportion of our young women today fall into this category. And unfortunately, there is a negative impact on the chances of live birth and risk of obstetric complications as well when you're talking about the high BMIs, especially in the order of over 35. And it's not unusual for any of us to see that kind of a BMI these days. Oocyte factor, age, and both are integrated with each other. And we have the difficult job of educating women about that and choosing the right oocytes, if at all possible, in an ART procedure. Parental genetic factors, we've always known that can have an effect on the chromosomes as well. And chromosomal abnormalities can have an effect on RPL as well. So in about 2 to 4% of RPL patients, that you may be able to find translocations, inversions, insertions, and mosaicism. And ASRM today recommends karyotyping of both parents, which I think we have been doing for quite a while. And it remains relevant despite a low yield. Yield is about 2.9% per individual. And in a couple, it goes up to about 4.77% per couple. And it can be anything like balanced reciprocal translocations, Robertsonian translocations, and sex chromosomal mosaicism as well, inversions and sporadic abnormalities. Depending on what the abnormalities are, we may have to resort to the right way of either choosing the sperm or choosing the right embryo. And parental karyotyping could be carried out after individual assessment of risk for diagnostic purposes. Products of conception, we used to, there's a big question whether you should check or not check the products of conception karyotyping in RPL. Karyotyping can rule out only major. It does not diagnose genetic level problems. It only looks at the chromosomes. And for that also, you require living cleaving cells. And culture failure occurs in a large number of cases while testing the products of conception. So you don't have to consider this as a regular part of investigating RPL. RACGH, if we're going to do it, it will be a better test when you're using it for products of conception, as it does not require cleaving living cells. And it's a better diagnostic test for the gene level problems if we are going to do it at all. So it's a conditional recommendation. And if we are doing it, RACGH is recommended, and that's a strong recommendation by the committees. So PGT-AS can be a method of choosing the right embryo if the abnormality exists in one of the couple. PGT-AS, however, we have to understand that whatever embryos we are getting out of an ART procedure, it does not really increase the number of embryos. It just chooses the right embryo. So there could be a chance that you may never get a normal embryo out of this couple. So you can't advise PGS as a very definite strategy for preventing loss in the next pregnancy. So therefore, ACOG does not support PGS to be done for this indication, for an RPL at the moment. So investigating the seed factor is the sperm, oocyte, and the embryo as well, that we have to look at all three to make sure that the seed factor is okay. Next factor is the soil factor, which can be either the endometrium and the uterine factor. This also, there's a lot that has happened in the endometrial factor. recently. And we have to, for that, we have to look at the concept of microbiomes. Microbiome is a terminology that means that a cluster of microbial microbiomes that are found in a certain cavity. And the first thing that we have to say is that the concept of sterile endometrium in the uterine cavity has become outdated. And most mucocutaneous surfaces in the human body today are known to harbor a rich flora of aerobic and anaerobic bacteria, and so does the uterine cavity. So today we accept the fact that the uterine cavity is not a sterile cavity. It does carry microbiome, which is a community of microbial agents. And out of this community, there are bacteria, viruses, and yeasts are all normal flora in the endometrium. And anaerobes are more dominant. And this is why we used to say that it's a sterile cavity, because all we are doing is an aerobic culture. Our cultures today, in the majority of places that we do routinely, are aerobic cultures, and you're not going to grow anything. You're not going to grow the viruses or the yeast and anaerobes in a regular culture. And the uterine microbiota, interestingly, differ from the vaginal microflora as well. The microbiota in the uterus normally more closely resembles oral microbiota. So most of us have heard the fact that the periodontal diseases can be associated with reproductive problems. So this is why, because if there is a periodontal microbial problem, it can get reflected in a microbial problem in the uterine cavity and give rise to recurrent loss of pregnancies as well. So general characteristics of bacterial community in the genital tract is like this. In the vagina, it's lactobacillus dominated, and which is low diversity, but there's a high abundance. The numbers are more, diversity is less, and it's mostly lactobacillus dominated. Whereas as the higher up you go in the genital tract, usually the diversity becomes much more, but microbiota levels are higher, less number of microbiomes. But at the same time, the diversity becomes much more, and the lactobacillus also becomes much less. This is what happens. Lactobacillus is more like a 99% if you look at the lower third of the vagina. But as you go up in the genital tract, the lactobacillus concentration becomes less, and you have a whole lot of other bacteria which you commonly cannot grow in cultures. And that is the problem. And eubiosis and dysbiosis, what happens is dysbiosis is when this microbiome changes in the uterine cavity, which can give rise to a different kind of an infection called chronic endometritis. And because in dysbiosis, the lactobacillus becomes less, and the other high microbial load becomes much higher. Abnormal microbial load becomes much higher. And this can give rise to immune stimulation. So it's the immune response that makes difficulty in conceiving for these women. And it also forms something like a biofilm inside the uterine cavity, which you cannot see with your naked eye. You cannot curate it out, and it is not susceptible for any of the antibacterial agents that you use. It's almost like a water film in a film that you see, biofilm that you see in a water tank. That kind of a layer forms even with dysbiosis, and it becomes stuck to the inner layer of the uterine cavity. We thought it was all a story and couldn't be really demonstrated, but once we started understanding this dysbiosis and understanding how to diagnose it, there are a lot of cases that we are seeing of dysbiotic chronic endometritis in the uterine cavity. This chronic endometritis is a problem that is unnoticed by patients because it's asymptomatic. Microbiomes might change and form this biofilm inside the uterine cavity, but it's almost always unnoticed by the patients, and it doesn't give rise to much symptoms. So even by the gynecologist, it's undiagnosed. But it's probably the most important remediable factor in early RPL. I think it is there, it exists, and there are many ways we can be, once we became sensitized to this and started looking for it, there's a whole lot of patients we are diagnosing it now in not only RPL, in an unexplained infertility as well. And unless we deep in it also in RPL and RIF, which is recurrent implantation failures in ART, these biofilms may be a problem. So I think this is one of the major issues now, which we are picking at and able to diagnose adequately and able to cure as well. And how do we go about it? It is something that the patient is not going to come and complain to you. There's no pain, there's no discharge, there's no other symptoms that she has. it is something that you don't find anything when you're examining because the symptoms are very mild and you don't have much of a tenderness, no fluid that you can pick up in an ultrasound, and those kind of things do not exist. But it can be there in up to 30 to 60% of the cases of recurrent implantation failure and 50 to 60% of the cases of early failures as well. So the reason that it becomes so important is because of the chronic inflammation and immune response to this biofilm that happens in the uterine cavity. And it's induced by the microbial antigens such as lipopolysaccharides and an altered cellular immunity that happens in the uterine cavity. Beta lymphocytes are usually confined to the basal layer. They proliferate and start occupying the entire functional layer. And these can be forming the plasma cells, and IgG and IgM are found in the stroma. So altered humoral immunity because of increased inflammatory cytokines, altered gene expression, and out-of-phase morphology, all of this is what gives rise to chronic endometritis and first trimester miscarriages recurrently happening again and again, as well as problems with ART procedures. Altered uterine contractility may also occur, and this is one major variation of what we have been doing earlier, is looking for, especially in early failures, looking for chronic endometritis. An important factor is, you've got to consider this as an important factor responsible for RIF and RPL. Incidence in many of the studies is now jumping up to 60% also. And if it is that difficult to diagnose, how are we diagnosing it? Diagnosis is actually based on histoscopy and histopathological examination, separate microbial culture and molecular diagnostic tools, and all of which are available for us today, and we can do it. And in prevalence, it also has a prevalence in some infertility as well. This histoscopy is a must for diagnosing this entity, and it has a very typical appearances, which you may even overlook when you're doing a histoscopy because it's not dramatic, and we can have to look for it when you to find it. And it can be, this is called a strawberry endometrium. It's hyperemic endometrium with white central spots all over. It's because of increased vascularity in those areas. And you don't see the biofilm I talked about. What you see is this kind of an appearance. This is strawberry appearance is seen in 65% of the cases of CV. And it can be seen in only some spots. It may not be all over the endometrium, but it has a very good specificity and sensitivity as well. And other classic pictures are microvilli. You can see in the second picture and even in the first picture, small villi. The villi are only about 1 to 2 millimeters and can be easily missed. So it looks like a shaggy endometrium. If you look close to it and sort of start looking at it, you see these villi, small villi projecting. It's not a dramatic polypoid. It's micropolyps are what they are called. And micropolyps are in some places in the uterine wall or in all of the places in the uterine wall. So it's strawberry appearance in some areas, micropolyps in some areas, which are classic pictures of chronic endometritis. And this can lead on to what we call a chronic deciduitis and diffuse extensive plasmacyte infiltration in the basal plate of the placenta as well. So it not only gives rise to problems with infertility, recurrent implantation failure, recurrent pregnancy losses early in the first trimester, it can also be linked to some of the preterm labors that we are seeing, the dynamic cervix that you're seeing, where the cervix opens and closes and becomes shorter, whatever you do with all the progesterones that you're giving, and later on, what are all the other agents that you're giving to decrease the uterine activity. It will come back again and again, and you wonder what's happening. It might be a manifested, this type of a preterm labor, which you're finding difficult to suppress with your usual modality of treatment. There could be an underlying chronic deciduitis. Cerebral palsy can be another thing. Preconceptional chronic endometritis rather than an ascending infection during the gestation. So this infection didn't happen during the pregnancy. It happened much earlier, formed that film inside the uterine cavity. So it's more common in IVF pregnancies linked to all of these things: preterm labor, periventricular leukomalacia, cerebral palsy, all of these things. And it can improve with therapy. Only thing is, and then there's a lot of papers coming out of Japan now where the implantation rate becomes much better, live birth rate becomes much better, the clinical pregnancy rate becomes much better. The only thing is the improved outcomes happen with common antibiotics, but then many times we have to repeat the antibiotic therapy 2 or 3 cycles to get the improved odds and keep monitoring the endometrium with ultrasound. Even you can do that. And all of these are preventable problems. Next factor is the uterine factor. The uterus itself may be the non-receptive soil. Uterine abnormalities, both congenital and acquired, may lead to suboptimal implantation. Suboptimal implantation may ultimately result in recurrent implantation failure or recurrent pregnancy losses. Uterine septum, the good old uterine septum, and I think we've been overzealous about calling some things as septums and taking a cautery inside the uterus to the uterine sidewall or fundus, and it almost became a disease for a period of time. A lot of ART units were doing a lateral metroplasty or a fundal metroplasty for every one of their patients where they're putting in the embryos. Absolutely not needed. It's only a destructive procedure. You don't do it that way. The definition of a normal versus a septate versus bicornuate is this. Arcuate uterus, we don't touch arcuate uterus. You don't touch predominant lateral side walls. Its arcuate uterus can be anything like 1 centimeter below the fundal outline. Septate has to be at least 1.5 centimeters more, and the angle has to be less than a narrow. It has to be less than 90 degrees. And bicornuate, you will have a fundal indentation as well. So you cannot diagnose, septate uterus without looking at the fundus also. The fundal outline has to be very evident in your ultrasound pictures, and you have to be looking at the depth indentation, which should not be there. If it's there, it's a bicornuate and it's not a septate. So you have to have your definition of septate uterus absolutely okay before start taking a cautery to the uterus. That is what you measure. So all women with RPL should have an assessment of the uterine anatomy, and this can be a transvaginal 3D ultrasound, which has a high sensitivity and specificity and can distinguish between a septate uterus and a bicorporeal uterus. And sonohistography, which we use very extensively for a lot of these things, is much more accurate than a hystosalpingogram. HSG does not give you these kind of diagnoses. We talked about hysteroscopy, visual, and biopsies with for chronic endometritis. And here it's got to be either a 3D or a sonohistogram for you to make a clear diagnosis. 2D ultrasound alone is not a very sensitive method. Sonohistogram or hysteroscopy will be needed along with the 2D and a 3D. And next step is intracavitary pathology, the other acquired uterine malformations also. When you move on from congenital, you have to look at the intracavitary pathology, which may be some submucous fibroids or large endometrial polyps, which are also indicative of an inflammatory pathology. And again, it can be a 3D ultrasound, sonohistogram, or hysteroscopy. We use sonohistograms extensively in our workup of infertility patients and early losses as well. An MRI could be a good diagnostic modality, even though it's a bit more expensive as well. And fibroids, if you take it, molecular and physiological effects are there, endometrial receptivity markers are there, and critical for implantation. Decreased in endometrial biopsies in women with submucosal fibroids. So you can't say submucosal fibroids are, it's okay and they do not give rise to infertility any longer. And you know that even in there could be changes in the molecular and physiological part of it. And also in leukemia, inhibitory factor and cytokines and growth factors. And all of these factors become impacted in the endometrial cavity. The implantation may be altered and give rise to problems. So the only thing I wanted to point out was the larger fibroids, which will naturally distort the endometrium, are larger than 2.85. Once upon a time, we used to say, if it's a polyp, if it's polypoidal fibroid, if it's more than 2 centimeters, and if it's a uterine wall fibroid, it's more than 5 centimeters. It's important. But not anymore, and it's also makes sense because the normal uterine wall is only 2.5 or 2.8 centimeters. And if your fibroids exceed in size and they're intramyometrial, they have to project one way or another. And a lot of times they project inside the cavity, and that is important. And that with an ordinary ultrasound may be difficult for you to find out. So we insist that we find in these situations fibroids, all of them we should be labeling with a FIGO classification. In other words, all of these things, this way is what we do. Fibroid number, the site of it, the extent of it, FIGO classification, which one it's 1, 2, 3, or 4, or least distance from the cavity, least distance from the serosa. And this kind of a workup should be there for each of the fibroids. For example, this is a fibroid. Right side is a picture without sonohistogram. Look at it, you may even ignore that there is a fibroid in there, even though there are some shadows in there, and it might very well be overlooked. But here with the sonohistogram, you can see very, very clearly that half of that fibroid is actually within the cavity. So again, sonohistogram becomes an important modality of imaging for us, modality and regular part of imaging for us, because we pick up an awful lot of pathology when we do a sonohistogram along with the regular ultrasound. Again, you can see, these pictures, it's very easy if you do a casual ultrasound, how much you can miss it. The fact that the entire thing or almost the entire fibroid is sticking into the cavity and can give rise to repeated implantation failures or repeated early pregnancy failures. So if there is a fibroid, you cannot overlook saying that it's only a 2-centimeter fibroid away from the cavity, which you might say looking at the pictures on the left side. So you have to look at it one step further, either with a MRI or with a sonohistogram. And if you have multiple fibroids, it's better to go for an MRI rather than a sonohistogram, because of the simple reason that ultrasound doesn't pass through one fibroid. And if there is one fibroid behind another, you're not going to pick it up. So this is the kind of imaging you're going to get with your multiple fibroids. And then it's easier for you to make a decision of what exactly you want to do. So those fibroids are extremely difficult to take, for diagnosis with plain ultrasound. Adenomyosis, again, very important pathology that we need to pick up in RAL. Asymmetry, what you look for is asymmetry of myometrial walls. You can see the anterior wall of the uterus is about half the size of the posterior wall of the uterus. If you get an asymmetry like that, think adenomyosis. Even if you don't have any other signs or symptoms, if that asymmetry should make you think about adenomyosis. Heterogeneous myometrium with hyperechoic areas, hypoechoic areas, those are called striations, streaky, pencil line, Venetian blind appearance, whatever you call it. This is again declarative of adenomyosis. So though it's a difficult, slightly more difficult diagnosis to make, if you pay attention and adjust your gain settings in your ultrasound machine, these should be easier to pick up. And when you have difficulty in diagnosis, MRI pictures give you beautiful pictures of focal adenomyosis, how much of the uterus is involved, where the pathology is. Over a period of time, I've seen people calling it an adenomyosis, taking the top half of the uterus out. And I think it's the worst possible surgery that one can do, because your adenomyosis can be sitting like this in the lower part of the uterus. So you have to define focal adenomyosis exactly where it is, where you have the normal tissue, where you have that adenomyosis, before one even starts thinking about the possibility of surgery. And here you can see the diffuse adenomyosis, again, chopping off the fundal part of the uterus isn't going to do any good in these kind of uterus. It's only worsening the situation rather than this thing. So adequate amount of appropriate imaging is necessary, and adenomyosis should be ruled out in RPL. Fibroids projecting into the cavity is tumescent. Okay, again, for somebody who's had one previous cesarean section, this, we are seeing this pathology not uncommonly at all. Okay, and there's a chronic inflammation and chronic infection associated with isthmoseals in the defective cesarean section scars. Polyps and other pathology should be looked for and ruled out. So endocrine pathology, luteal phase defect, can that be? Why are we using progesterone as a universal treatment? LPD and resultant progesterone deficiency is not a spontaneous standalone entity, and it's not a standalone entity which can cause RPL. LPD is only secondary to hormonal manipulations during fertility treatment or secondary to other hormonal problems like thyroid or prolactin problems. And it doesn't happen all of a sudden on its own. And it's actually never been proven that all early pregnancy problems are only secondary to progesterone deficiency. And it is actually, if you look at the entire science of it now, it seems illogical to expect all RPL to positively respond to progesterone. And I think we know that massive studies have been done on all kinds of type of progesterone, when you started, before pregnancy, after pregnancy, what type of pregnancy, how long you carry. You know the major studies that have been done. But at the moment, the conclusion that it's even illogical to expect all RPL patients to positively somehow respond to progesterone management, because that luteal phase defect is not the cause of recurrent pregnancy losses. Empirical progesterone therapy in the luteal phase in very large trials have been done. First trimester vaginal progesterone placebo have showed no increase in pregnancy rates. We all have heard about PROMISE trial and other very large multicentric trials. And none of them have really proven luteal phase deficiency or a significant improvement in the outcome with women with unknown causes of RPL. When you're not diagnosing them, just putting them on progesterones is not going to make any difference whatsoever. Thyroid screening is recommended in women with IPL. Abnormal TSH level should be followed and corrected before pregnancy. General systemic things are actually more important. Assessment of PCOS, in that it's not PCOS, it's fasting insulin, fasting glucose, and insulin resistance can give rise to all kinds of problems in pregnancy. So I think if it is there, metabolic derangement should be corrected. Androgen testing is again not recommended for women with RPL. So these are the hormonal things that we are, used to doing, and some of them have become questionable, and some of them have become more valid. So the environmental problems, embryo endometrium interaction and immune pathologies, this is something that all of you have read about and heard about and keep hearing about again and again and again. So I'm not going to go into a lot of details about it. It's there for you to read in any recommendation, any committee recommendation. And right now, what is recommended by all of the committees is screening for APLA after 2 pregnancy losses. For women with RPL, screening for beta-2 glycoprotein also is recommended. Screening is recommended. Anti-nuclear antibody testing could be considered for explanatory purposes, but probably doesn't contribute much to the treatment part of it. For women who fulfill the laboratory criteria of APS, with a history of 3 or more pregnancy losses, low-dose aspirin is suggested, and a prophylactic dose of heparin starting at a date of positive pregnancy test gives you a better outcome, and it's a conditional recommendation. And the GDG also suffers guidelines. Committees now suggest offering anticoagulant treatment for women with 2 pregnancy losses in APS in the context of clinical research, but it is something that is recommended. And again, when you get into the ART scenario, there are all kinds of things now which are being tested and which are being treated. Most of them do not have any valid underlying reason. Insufficient evidence to recommend NK cell testing, peripheral blood, or in the endometrial tissue. Again, NK cells are cells which are found in the periphery normally, and during a pregnancy, there is a different kind of NK cell that's found in endometrial tissue and in the peripheral blood, and you have to check it in the endometrium for it to be valid. But again, there is no evidence today that it contributes in any way for your management of APLA. HLA determination is not recommended again in clinical medicine. So inherited thrombophilia, again, inadequate evidence for association between inherited thrombophilia, homocysteine levels, and recurrent early pregnancy losses. So these things are not to be checked regularly for all of the early RPL as well. But parental health indicators are important. Maternal obesity significantly carries a risk. So striving for a normal healthy range BMI should be recommended. How you do it is difficult, maybe difficult for you and your patient, but I think that recommendation is required. And I think amazingly now with group therapy, like in other words, you offer them everything in a professional way, it seems possible to deal with this pernicious problem, but where we are finding much more BMIs are over 35 and you're obligated to do something about it before you do that. Smoking, yes, we've got to stop it. Alcohol, stress. Again, this younger generation, we have to ask and we have to look at all of these things, deal with them also. So if you've got an unexplained, you've done all this and it is still unexplained, what next? And there are currently society recommendations, many societies recommendations. This is ESHRE's recommendations. A treatment of unexplained RPL. Heparin and low-dose aspirin are not recommended as there is evidence that they do not improve live birth rate in women with unexplained RPL. There are enough studies to say that. So just taking somebody and blindly putting them on aspirin and heparin, and I don't know, and if you take somebody, even if APLA positive, APLA is not really classified as a thrombophilia. In a thrombophilia, anticoagulants work, okay, not in other things. And then congenital thrombophilias in pregnancy are extremely uncommon. So therefore, that checking is not recommended. Lymphocyte immunity, this comes to the area of people who do a lot of ARTs, and all of these things get done if they find recurrent implantation failures or pregnancies failing in the early part, which may have very valid other reasons. Lymphocyte isoimmunization therapy and use of repeated and high doses of IVIG. Only place it's conditionally recommended is that it may improve live birth rate in women with 4 or more unexplained RPL. That's the only place that's recommended. It can have life-threatening complications, so we've got to be very careful using those kind of modalities. Glucocorticoids not recommended as a treatment of unexplained RPL or RPL with selected immunological biomarkers. Vaginal progesterone, again, is suggested in women with 3 or more pregnancy losses and vaginal blood loss in a subsequent pregnancy, in a 4th one, and it's a conditional recommendation. It's not for all of RPLs. There is insufficient evidence to recommend intralipids as well. Again, this can have its own complications, and you find a lot of units, especially RT units, using a lot of intralipid. Endometrial scratching, which was a fancy for a period of time, doesn't do any good. No recommendation for it. No recommendation for GCSF. Again, these are expensive modalities which have really no evidence, and it's strongly not recommended. Okay, no evidence to recommend CSF. Low-dose folic acid is routinely started preconceptionally anyway to prevent neural tube defects, but that also has not been shown to actually be treating pregnancy loss. And unproven indications with no scientific evidence is vaginal progesterone, except for particular indications, which are actually associated with infertility treatment, where you meddle around with their hormones. Heparin and low-dose aspirin don't seem to have much of a scientific evidence. Glucocorticoids, IVIG, intralipids, and GCSF and all that, we've got to be very careful about using those kind of things. Endometrial scratch also is no. So the take-home message is it's not a single homogeneous disease for us to be treating every RPL with the same medications and same approach. RPL is not the presenting symptom, is accepted now as the presenting symptom of multiple causative factors. So specific causative factors should be diagnosed before appropriate management is undertaken. And current ESHRE recommendations provide a framework for the approach and management. Treatment modalities in these recommendations, which are classified as not recommended, should not be used without establishing a specific diagnosis. And treatment modalities which are not evidence-based or have significant adverse side effects, extremely expensive or disruptive, should be totally avoided. So where do we go and what do we do? I think it may be difficult. Everything that I've outlined as the needed work for somebody with an RPL may be difficult for an average gynecologist sitting in their OP and has about 15-20 minutes to spend with this patient. So what we really need to do is dedicated recurrent pregnancy loss clinics, where you can have a group of doctors, each one of them interested in a separate area, genetics and histoscopy, all of those the facilities that need needed to be used in this kind of a situation. So you need that kind of a group activity. So it can be, a recurrent pregnancy loss clinic, which has all of these modalities available. And larger institutions having these kind of clinics is the need of the day, because none of them should be treated blindly with the same kind of medications without even looking to see where the problem exists. Thank you.
Thank you, madam.
Thank you.
We'll just have some questions.
Yep.
Yeah. It was a elaborate discussion. So anybody having questions can type in the chat box, or you can unmute yourself and ask too.
Madam, I'm Dr. Ambuda Girdhar from
Yes.
Coimbatore.
Yes.
How will you treat that DNA fragmentation, madam?
How do you treat DNA fragmentation? Because happens because of certain reasons. Okay. And a lot of them are environmental situations. It could be age over 37. Generally, you cannot treat it and you cannot take it back. But what you can do is you can separate it in the ART laboratory. It's possible to separate the sperm, either for an IUI or for an IVF. It can be done. So that kind of a treatment might work for them. But the rest of them are lifestyle related. A lot of them are lifestyle related. It may be exposure to something like pesticides, which I told you was one of the most common things that we are seeing here in India. And it may be alcohol, it may be smoking, it may be obesity, it may be any number of things, where exposure to other occupational hazards. All of these things could be used, and antioxidants can help also. If there's a varicocele, you repair it. So a complete workup of the male partner is essential to find out what the reason for this is, and then you have to address it. You can address the sperm, or you can address the individual, or you can do both.
Chromosomal microarray, where all you will suggest, madam?
Generally, in this situation, what is suggest is microarray for when you're checking the parents. But there's no point in doing karyotyping, is what is being said. CGS microarray may work.
Thank you, madam.
No point in chromosomal, because a lot of times it's not a chromosomal abnormality that's there. And also you have to have live culturable cells, which it doesn't exist in products of consumption. So in this context, that's one area where it can help when you're doing POC.
Yes. Madam, there is a question from Dr. Sudha. What is the indication to start heparin in patients with recurrent pregnancy loss?
I told you it's not even the thrombophilia that you're treating. Okay. So unknown and uninvestigated, there actually scientifically doesn't seem to be a reason for putting all of RPL on heparin. Which is the normal habit today. That's what normally gets done, right? Okay. So
Madam,
we've got to think, it's very difficult to change the way you think and do when it's universal. And when that's the standard, practicing standard is that. So I think it's sort of, we have to, this talk is just meant to say that it's not a disease, it's a symptom. And the symptom can have 10 different underlying causes. And without looking at it, you really cannot start putting them on a simple medication. And, that is why all these studies, the mega studies that you'll see, haven't really shown much improvement with progesterone, haven't shown much improvement with aspirin and this thing. And also, is that a thrombophilia that we're treating? What do you treat with aspirin and heparin? What are you treating? Even if you've proved, when you're testing for APLA and deciding that it is not APLA, you call it seronegative APLA and put them on the same medication, right? That's the standard of care today. So it's really questioning the standard of care that we are giving to these people. And I think we have to start thinking a little differently, looking at it a little differently, studying it a little differently. And once we started applying it, there is any number of sperm problems that we are finding, DNA problems we are finding, any number of chronic endometritis. That was why I sort of took that a little bit wider coverage on that. chronic endometritis is not as unusual as we thought it was, and it's a brand new entity. Microbiome is actually a colony of microbes, and each of our body cavities, oral cavity, sinuses, you look at any body cavity, gut, and every passage which is lined by mucosa has a microbiome, which is like a colony consisting of aerobic bacteria, anaerobic bacteria, viruses, fungi, everything. Okay. But not in aerobic isn't the only thing that we are capable of checking with an if you do a culture sensitivity today, and nothing else grows. Okay. So when in situations, that is why it's so difficult to treat chronic sinusitis. If you treat a chronic sinusitis, it doesn't respond to antibiotics in one time. Okay. So a lot of cavities like that. And we've all read articles which said that oral microbiomes, and if you have an infected gums and infected things, they're much more likely to go into preterm labor. Why does that happen? There's very good articles and proven studies where both are linked, oral microbiomes and disrupted pregnancies.
How do you treat chronic endometritis, madam? Like you feel they cause RPL, how to?
I wouldn't put people on.
Can you switch the video, madam? I think it was switched off during the presentation.
Oh, it was. You didn't see any of the slides?
No, that I couldn't see you.
Particular area, is it?
Now I'm able to see you.
Go back. I'll go back.
Yeah. Yes. Now it's fine.
Can I have the screen?
We're able to see you now.
Yeah, I can't see the slides. I don't know. Slides open. Share screen. Slides open. No. Okay. Can you see the slides now?
Yes, madam. Yeah. They're asking the role of CD138. If it is positive, how will you treat it?
One second. Okay, can you see the slides? I'm just going through the whole chronic endometritis slides. Okay, it's not the same as acute endometritis. It's clinically silent, minimal symptoms, if anything at all, mild pelvic pain, maybe a little bit of discomfort or leukorrhea. No typical obvious clinical or ultrasound findings. However, long-lasting reproductive outcome. Okay, 30 to 60% of recurrent implantation failures in the context of our ART unit. We are much more aware of it, and wherever we get an implantation failure, we check for it. Okay, and wherever you get an unexplained thin endometrium, you would have seen them. I'm sure you would have come across previously normal endometrium, and you start doing a procedure, it doesn't grow. It doesn't matter how much of estrogen you're throwing at them, it doesn't grow. Okay, situations like that. Okay, and these are the things that happen. Okay, the classic thing is histoscopy. Histoscopy, once you do it, you take a biopsy. Okay, I talked only about histoscopic findings. The micropolyps, the red areas, you can ignore it. When you're putting a scope in and there's nothing massive looking at you, you tend to say that it's normal. Okay, you put your scope in, it goes in. Some little red areas, other than that, you're expecting to find a polyp or a fibroid or adhesions or something like that. Okay, if you don't find it, you tend to call it that, because these ones, you have to put your mind to it and you have to look for it. And this is the typical strawberry appearance. This is the typical micropolyp, and it may be even more prominent than that, and areas where the vascularity is higher. And if you're doing ultrasound, if you have a habit of doing sonohistograms, it can be loculated fluid in the endometrial cavity. Okay, so you'll be injecting your normal saline to do a sonohistogram, and the fluid doesn't flow freely. It's not like a solid obstruction that you get with an Asherman's. They're not that kind of a adhesion, but these are adhesions that even if the fluid goes under pressure, it will open, but it will get loculated in the cavity. So I unfortunately, this is not a chronic endometritis presentation. That's a whole different presentation. And if you do that, then you take here, this is visual diagnosis with your ultrasound, but this goes into special labs for plasma cells, checking plasma cells. Okay. And that you have to have somebody who will do that for you. Okay. Not all ordinary labs can look at plasma cells for you. And if you find plasma cells, then you have to treat it. And originally there was confusion as to when it becomes important. Okay. And now they find the consensus is that even if you find one plasma cell in the endometrium, it's abnormal. So you do that. So it goes for culture. It's not ordinary cultures don't work. It's the genetic ones that you have to do. What kind? There are special panels that pick up for it. There's one thing called DICE panel, DICE, DICE panel, and that is for chronic endometritis. So we send it for microbial tests and molecular diagnosis. It's not usual culture diagnosis, molecular diagnosis. So it's usually the DICE test and looking for plasma cells and then the biopsy. And of course, we always rule out tuberculosis also, given that we are doing it in India.
What test do you do for ruling out tuberculosis, madam?
Tuberculosis, I don't want to get into it, because I will tell you something, because I've lost interest in checking for tuberculosis. My friends in Delhi tell me that 50% of their cases of tuberculosis, I've been probably practicing 3-4 decades or 5 decades. None of my biopsies ever come back positive for tuberculosis. The kind of tuberculosis is extremely rare in the population that I'm dealing with, unless it's something very funny looking. I don't know.
So CD138 or a plasma cell is present. What antibiotic or what is the modality of treatment that you follow in your clinic?
It is not anything special for plasma cells. Okay. It's a diagnostic cell for chronic endometritis. Whether it's there or not, you might have diagnosed it only with the polyp, only with the localized, loculated fluid. It's the whole thing you put together. You don't have to have a plasma cell. Plasma cell, as it was considered earlier, it's not considered as mandatory any longer. Okay. So you can make a diagnosis of chronic endometritis without the presence of plasma cells also. So if it's negative, it doesn't mean that you've ruled out chronic endometritis.
Do you give doxycycline for 14 days as the first?
Yes. We include doxy and maybe tinidazole or something along with it, and you give it for a more longer period of time. But I'll also tell you, it very seldom clear, and it's not just my experience also. It's published material. The person who does the most work on it is a Japanese guy called Ciccinelli, Cicenelli. You look it up, and he's got a lot of work published on it. And it often needs about 3 cycles at least for you to repeat the procedure.
Okay.
Good evening, madam. One would like to ask.
You need to repeat antibiotics 2 or 3 times. Okay.
Good evening, madam. One doubt, madam.
Yeah.
Nowadays, with this vaginal pessaries, with all this combination of antibiotics, have they got any effect, madam?
No, whatever you put in the vagina doesn't go to the uterus.
Or when we are doing sonohistogram and we see such a picture, or when we are doing hysteroscopy, can we instill the antibiotic directly?
It'll be there for half an hour. Doesn't get absorbed, and it doesn't do much good. We've tried it in very resistant cases. It is suggested intrauterine instillation, but if you do it along with your hysteroscopy, it's going to get washed out anyway.
I just thought with this people biopsy syringe, can we just instill regularly or something like that?
Whichever way, people, you can, any biopsy tube, any longer cannula would do that for you, and you can do that. But you don't need to enter the cavity. Majority of cases, only when they do not respond to several cycles, very rarely you may have to think about it.
Counseling is very difficult in these patients, madam.
Counseling is always difficult in RPL.
Thank you, madam. Nice talk, madam.
I know I purposely made the unusual things a little bit more prominent, and I didn't want to get into the APLA discussion back again. And I'm sure you hear endless discussions about APLA. I've heard brilliant discussions by very good people going through every recommendation of APLA and what we're doing with heparin and aspirin and stuff, and not come up with one single evidence for actually management that way. If you
Yes.
take the whole APLA, okay.
There is
I've done
something
it's all
about
uh,
any role of immunoglobulin and RPL.
that's what I said. Don't go for expensive treatments.
Yeah.
What are you treating?
Madam, how to treat if there is dysbiosis? Do you give probiotics to
Yes, that is one thing that we do. Yes.
do you continue during pregnancy, or you just treat them with 2 months course and then ask them to plan for pregnancy?
We usually get rid of this infection before we start the ART, or if it's an infertility management that's needed, we treat this first and then go for the ART treatment.
Dr. Janani has asked role of hydroxychloroquine in RPL.
None.
I think any other questions anybody wants to ask?
Thank you, madam. It was an excellent presentation and you gave a clear picture. Thank you.
Thank you. Thank you.
Thank you, madam. So I think it was beautifully presented on any number of we talk
this
about
requires, this requires whole RPL requires a whole day or 2 days or 3 days of you doing it, which I think needs to be done sometime or another. And you were saying something.
Yeah, especially that only, madam. RPL is such a big topic. How many ever times we want to learn it? Again, it will be a question what to treat with this patient.
No, because still most of the people, see, why are we testing for APLA? Not finding it in the conventional way of doing it, and then calling it seronegative RPLA and treating them with the same medications.
Yeah, we don't know.
If it is an RPLA, where does it get classified? It's classified as immunological problem, right? Okay. Why are we treating it with aspirin and heparin?
Definitely. We had a patient
that we have asked,
mutation which was non-significant. So, but she had 4 miscarriages. Then we transferred a euploid embryo. And anyway, we didn't have the guts to not start, but we stopped it at 8 weeks. Once everything was set and we stopped it at 8 weeks, she continued till delivery and then delivered the child very well. So she didn't needed heparin throughout the pregnancy. So there are patients who are having a different problem altogether. So treating all the patients of RPL with heparin we also did a workshop on beyond heparin and aspirin. What is RPL? That's I think the talk of this.
Is exactly what I've done today, that beyond heparin and RPL, because RPL is a symptom, it's not a disease.
As you told, we have to set up a RPL clinic and where we can sit and sort out the patient's problem and lifestyle in a better way so that we take enough care of them, not in the busy OPD where you hardly can spend time with them. So we have to have a fixed questionnaires and a fixed checklist to check where we are going wrong. So fantastic, madam. Thanks for your time and efforts to present to us. Thank you. Thanks a lot.
I've met you and the rest of the members of Foxy as well.
Yes. Thank you. Thank you, madam.